Myasthenia gravis is a rare chronic autoimmune disorder that affects the neuromuscular junction. It is characterized by muscle weakness that worsens with activity and improves after rest. The condition is caused by autoantibodies, most commonly those that attack acetylcholine receptors, which disrupts the communication between the nerves and muscles and thus prevents muscle contractions. The most common initial symptoms of myasthenia gravis are related to ocular muscle weakness, such as drooping eyelids, ptosis, and double vision, diplopia. For many, the disease can progress to a more generalized form, causing weakness in the face, swallowing, and limb muscles, typically occurring within 2 years. Women are more frequently affected. 10 to 15% of myasthenia gravis cases are associated with thymoma, a tumor of the thymus gland. A 25-year-old woman presents to her physician with difficulty chewing and swallowing food. She also complains of occasional double vision and ptosis of her right eye. She states her symptoms are often absent in the morning and appear to worsen as the day progresses, but can improve with a nap. What is the most likely diagnosis? The most likely diagnosis is myasthenia gravis. The term myasthenia comes from the Greek words mys, muscle, and asthenia, weakness, meaning muscle weakness. Gravis is a Latin word meaning heavy or severe. The differential diagnosis of myasthenia gravis includes Lambert-Eaton syndrome, which is a paraneoplastic syndrome associated with small cell lung cancer involving muscle weakness. However, strength improves if a contraction is maintained. In myasthenia gravis, symptoms worsen as activity progresses. Lambert-Eaton syndrome also typically spares the extraocular muscles. What patient characteristics are typically associated with myasthenia gravis? The age of onset of myasthenia gravis follows a bimodal distribution, with females most commonly diagnosed in their 20s and with male incidence peaking later in life, typically after age 50. What signs and symptoms are commonly associated with myasthenia gravis? Myasthenia gravis patients may present with a variety of findings, including ptosis, diplopia, dysarthria, difficulty chewing, and difficulty swallowing. Proximal muscle weakness is usually greater than distal muscle weakness. Weakness increases with use of the muscles, making symptoms more prominent later in the day. In myasthenic crisis, the weakness can become so severe that it results in respiratory failure. What is the pathophysiology of myasthenia gravis? The majority of patients have autoantibodies against the acetylcholine receptor, found on the muscle membrane at the neuromuscular junction. The binding of these autoantibodies initiates an immune reaction that results in decreased numbers of acetylcholine receptors. When acetylcholine is released from the motor nerve terminal, there are fewer acetylcholine receptors available to bind. Therefore, muscle stimulation is decreased, resulting in weakness. Some patients instead express antibodies against the muscle-specific receptor tyrosine kinase. Muscle-specific receptor tyrosine kinase is a protein that mediates the clustering of acetylcholine receptors at the muscle cell membrane. What tumor is commonly associated with myasthenia gravis? Myasthenia gravis has been associated with an increased frequency of thymomas. It is thought that the thymus is the site of production of autoantibodies against acetylcholine receptors. How does the tensilon test help to diagnose myasthenia gravis? Edrophonium, tensilon, is a rapidly acting acetylcholinesterase inhibitor that has a short-acting duration. It inhibits the breakdown of acetylcholine at the neuromuscular junction, thereby increasing the amount of acetylcholine available to stimulate muscle contraction. Thus, increased muscle strength immediately after the injection of edrophonium is suggestive of myasthenia gravis. What is the treatment for myasthenia gravis? Acetylcholinesterase inhibitors, which prevents the breakdown of the neurotransmitter acetylcholine, especially pyridostigmine, treat the underlying symptoms and may be enough on their own. Immunomodulating agents such as glucocorticoids or azathioprine are often used with frequent exacerbations or poor control. In myasthenic crisis, plasmapheresis and intravenous immunoglobulin can provide rapid relief. However, it is also important to closely monitor patients' respiratory status with frequent pulmonary function testing. Thymectomy is considered for all younger, less than 60 years patients with thymoma, and has even been shown to be of some benefit in patients without thymoma.